Hello and welcome to Tailoring Neovascular AMD Therapies. This continuing education activity is provided by Vindico Medical Education and supported by an educational grant from Genentech, a member of the Roche Group. I'm your episode host, Dr. Durga Borkar, Associate Professor of Ophthalmology at Duke University School of Medicine in Durham, North Carolina. And today I'm joined by my friend and colleague, Dr. Ferhina Ali, vitreoretinal specialist at Westchester Medical Center and assistant professor at the New York Medical College. Thanks for joining us, Ferhina.
Great to talk with you today, Durga.
During this 2-episode series, we'll review cases that assess durable and effective therapeutic options to optimize outcomes for patients with neovascular age-related macular degeneration and diabetic macular edema. In this episode, we'll focus on neovascular AMD. Dr. Ali, would you like to present your first case?
Sure. So this is a case that really highlights where we are in terms of newer therapeutic options, and particularly longer acting device delivery systems like the port delivery system. And so it's a case for my colleague, Dr. Arshad Kanani, really, once we had this product available to us, how we are thinking about incorporating it into practice. So I am beating to the punchline here, but I do want to share that this is his case. It's an 84-year-old woman. She's a female. She's retired. Her medical history is notable for arthritis, for which she has a challenging course in terms of medical management. And her ocular history is notable for open angle glaucoma in both eyes. So she had been well managed on injection therapy in both eyes. We see in the clinic that her OCTs look to be really well-controlled disease with the absence of fluid in both eyes. She had been coming every 2 months for intravitreal injections in each eye, and she is a patient who is not comfortable with bilateral same-day treatments, although that was offered, and so she was receiving alternate treatment for both eyes, then resulting in monthly visits for her, which was a significant burden, particularly given her age and her other comorbidities. So there was an interest in decreasing the burden of her having to come into the clinic. And so the plan was to insert the port delivery system into her right eye, continue on with treatments in the left eye. She would receive ongoing monitoring. But, in this early period, we're thinking about, when we start incorporating the port delivery and that surgery for our patients, how do we follow them? And in this patient, it's sort of an easy idea because she's coming in regardless for treatments in the fellow eye. So we'll talk a little bit about how that was coordinated. First, some highlights from the Archway and Portal trials. We learned that in those patients, 95% of those patients didn't require supplemental treatment at any interval through week 144. So really impressive data from the port delivery trials, data that we haven't seen durability like this in any other trial. That being said, it is, of course, a different mode of delivery, but very impressive results. OCTs remaining dry over months and months and months and not requiring any sort of intervention or the in-office refill procedure for a long period of time. We also saw in those trials that individuals maintain their vision and retinal anatomy for up to 5 years. And it is associated with a trend towards less atrophy progression, something that we have been thinking about and have been concerned about over the years and years of our patients receiving intravitreal anti-VEGF therapy. So this was a good way to kind of study this result and this endpoint. So we did see that in the patients that received the port, they had a trend towards less atrophy progression that we were able to observe over time. Interestingly, we also saw from those trials that patients did prefer the port delivery system over intravitreal injections. So we saw in those individuals that were in the arm that received the port, very high level of satisfaction as 93% with that preference. And even those that switched over to the port after having received injections as part of their randomization, still a high percentage of preference for the port as compared to intravitreal injections. And so actually Arshad Kanani's group did spearhead the real world summit study, which was basically trying to understand, okay, once this product is available for commercial use, how did patients do when they received it for its first indication, which was neovascular AMD? And what they found in their real world all comers receiving the port delivery system for AMD over a collection of practices across the country, that patients did quite well. Their mean refill duration was at 6 months. And the time to refill was quite impressive and a very, very low rate of needing supplemental injections. So what was seen for this patient, her surgery was successful. There is usually a slight dip in vision after that initial procedure. It is, done in the operating room. It is an anterior segment essentially procedure that is performed. And so we can see a slight decrease in their vision thereafter, but it recovers well. And so this patient continued to do well, absence of fluid on their imaging in the clinic at 1 week, 1 month, continuing onwards, maintaining very good vision of 20/30, which is where she was at her baseline. And what he employed here, which I thought was interesting, was sort of a treat and extend, but for the port delivery system. So in other words, planned for a refill as, studied at 6 months, and then was extending the refill thereafter to then 7 months, 8 months. And this patient continued to do well and be fluid free, maintaining really good vision. So Durga, I'm curious, we've been seeing the port delivery through the ladder, archway, portal, and then out for the DME trials, which we can discuss at another time. But I'm curious what you have seen to interpret the data to be in terms of incorporating it into your clinical practice.
Yeah, great question. I think this is a great case and great use of this new device that we have. A couple things. I think it's interesting. One of the things I've thought about, and it's you see it done very nicely here, is how do you extend that refill interval? Because in the trials, it was structured at every 24 weeks, and certainly visits were very standardized. But patients are looking to have decreased visits too, not just injections. And so I think this treat and extend approach is really nice. I think for this patient, she was coming in anyway to get fellow eye injections, but you do wonder if there's a role for something like home OCT in the future so that you can even decrease the visit burden even further. I think the question I have is, she's done so well when they want to do the fellow eye, so she won't need to have intravitreal injections there. But this is a great case. Would love to hear about your other case as well.
Great. Yeah, I agree with you. I think we're learning more as we go, and this hasn't been available for that long. And so we'll continue to learn more. And I would suspect this patient would likely be getting a port in her other eye in the future. But on to the next case. So this is a 76-year-old female. She has a history of new onset wet macular degeneration, referred to me after receiving a single intravitreal injection of bevacizumab. She did respond well to that treatment, and she presented with good vision, and she maintained good vision through her initial treatment. And we'll get into that in just a moment. But I'm curious to know, how you start thinking about patients now that we have newer agents available with greater durability. We have a newer mechanism of action. We have a higher dose with aflibercept, and sort of what may guide your decision in terms of the agent of choice if a patient either presents de novo without having received prior treatment, or maybe received initial treatment based on step edits or preference with bevacizumab.
Yeah, those are great questions. We certainly don't have any head-to-head data looking at these newer agents. So a lot of that decision making is sometimes very, very personal. It can change from patient to patient. I certainly think that I have a lot of patients that are doing well on aflibercept 2 milligrams, for example, but that durability isn't quite there. So then it's an easy transition over to aflibercept 8 milligrams for those patients. I think for other patients, where maybe they're on bevacizumab and I can go straight to one of these novel agents, there is a little bit more decision making. There's some data to suggest that in terms of these larger PEDs, that maybe faricimab can help decrease that PED height and disease activity. So I may try that there. But to be honest, I don't know that we have great head-to-head data to tell us a right or wrong answer. I think both of these agents work really well.
Great. Yeah, I would agree with you. This patient presented to me when aflibercept 8 milligram had not yet been approved for AMD, but faricimab had become recently available, I would say, within the past 6 to 9 months. And she heard about the 4-month drug, and she was very interested in it. And her insurance allowed for me to choose what I preferred to use. And so in this instance, I wanted to start her on faricimab with the loading doses. We saw very good data from Tenaya and Lucerne showing gains in vision vision and decreasing and well-maintained anatomy over 2 years. And in particular, as you mentioned, these newer agents have been studied to really understand their potential for durability. That's how those trials were designed and sort of pressure tested in that way, in addition to the efficacy and safety that we are customarily interested in. And what we saw in those trials were approximately 80% of those patients achieving 12-week or greater dosing. So hence the interest in the 4-month drug for this patient. And real world data has also supported the proxies and sort of signals towards potential for increased interval between doses for patients. So we started her on faricimab and she did quite well. She, had an initial great response to treatment, having presented with not very significant disease. We are catching patients earlier and earlier than we ever have been before. And we continue to maintain good vision of 2025 to 2030 for her, extending to 6 to 7 weeks and sort of marching forward, trying to gain more time. However, she did have a disease recurrence at 7 weeks. I tightened the interval at that time and brought her back to 6 weeks, but she is and was very interested in more time between treatments, not very much a fan of getting injections. And so at this time, aflibercept 8 milligram was available. And so we switched to that agent and she did well on it. And we were extending out her treatment intervals with that. And I believe she went out to 10 weeks and that's where she is currently. And she's doing quite well with that. And so I'm curious to know what your experience has also been with aflibercept 8 milligrams for neovascular AMD. I agree with you that I do have many patients who are doing quite well on 2 milligrams and have accepted the treatment burden. And I haven't necessarily pushed to switch all of them to 8 milligrams, but there are many patients who are interested in more time. And that has been a strong motivator towards that switch as well.
Yeah, I agree. I think that for those patients, it is all about durability. It's interesting because when you make that switch from aflibercept 2 milligrams to 8 milligrams, I'm thinking a lot less about doing those standard loading doses that you see in the clinical trials and more just trying to extend them from where they're at. Sometimes with faricimab, if I'm switching from aflibercept 2 milligrams to faricimab, I'll still try to load them if they're interested. But in general, it has been a kind of smooth transition from 2 milligrams to 8 milligrams in terms of, just extending treatment intervals, and patients do quite well. It's interesting that you had in this patient's case, they did well with faricimab, but they kind of hit a wall in terms of the interval and then did better with the aflibercept 8 milligrams. I think we certainly see patients where the opposite is true. And I think we're still really trying to figure out what OCT biomarkers or what kind of disease activity we should be looking at so that it isn't such method of, we'll try one first, see if it works, and then switch to the other, which I think is currently what a lot of us are doing.
Yeah, those are really great points. And I think, sort of in terms of what we've seen with aflibercept 8 milligrams with the extension data, it is really impressive in terms of the durability. The last completed dosing interval for those that switched from 2 milligrams to 8 milligrams was 12 weeks or greater in over 80% of patients. So we have a lot of really strong data. It's always interesting to see how these treatments perform in the real world. We're beginning to see more real world data for aflibercept 8 milligrams, which really does validate so far increased interval after these patients are switched to 8 milligrams that we've seen out of a data set from Wills and I believe RCA, corroborating the findings we've seen in the clinical trials. And we'll await more real world cases and real world data to kind of understand if there are indeed biomarkers that can guide us towards tailoring agents to particular patients.
Well, thank you, Dr. Ali, for the excellent discussion, and thank you all for listening. Please remember to take the post-test and evaluation to receive CME credit and to tune in for additional episodes within the podcast series.